participation for these webinars is up to 1,000 people. So there's a little bit of wiggle room, and please tell your colleagues that this webinar is every Monday and they're welcome to join. I wanted to make sure that you know that we do record these webinars and post them on our website. So if you miss one, you can go back to it, and the slides will also be posted there too. And to visit Doris's COVID-19 blog, this will answer many of the questions that you have as well, and just to keep yourself up to date. And this is our team supporting today's webinar. So Olivia is behind the scenes. She's a project coordinator at RNAO. That's me, Susan McNeil. I'm a senior program manager. Doris will join us shortly. Frida is also supporting us behind the scenes, and she's one of the long-term care best practices coordinators. Heather McConnell, you can see her picture, I think she's waving. And Heather McConnell is an associate director with guideline implementation and knowledge transfer. And Irma Jean, I think you can see her also on the screen. I think she had her camera on. And Irma Jean is the acting director in our policy department, as Matt Kelway has been seconded to work with the inner city team. So that's who's on the call now. And Heather and Irma Jean, I think you were both on the NP call that just happened, right?
Yes, we were.
Okay, great. So we'll just give it a few more minutes. I'm going to turn my music back on for we'll get started momentarily.
Nice music.
I'll turn it down now.
It's nice.
Yeah, that's
okay.
It's drowning out the loud winds that are coming from my place. Yeah.
Also here.
Right. Yes.
Me too.
So I had the CP24 cancel on me because I basically said to them that I'm not taking them in person. Tough luck. It's the only outfit that still wants interviews in person, and they're risking their own people. They shouldn't be doing it. In any case, let's keep going, because we are going and going, all of us. I feel that we don't stop ever, and so do my colleagues. 182 and growing online, they're waiting for us. So can we put first, can you unmute and put the pictures just so we can see kind of faces a bit before the click, click, click even? Listen, I have never received the click, click, click picture, Susan.
Okay, well, I need to get on that for you. Yeah, because we did take
times, so we can.
Yes, sure. Yeah, I'll make sure
I can put them in the report.
Tweet it. Yeah, absolutely.
Can you send me tonight?
I think we can send you previous ones. It takes a while to download the video.
Previous ones, I don't have any.
Yeah.
And we can put them and say during the webinar, and it will be nice.
Yes, so Olivia needs, and what we were planning on doing is actually, I've set my alarm for 7:15 to put people as panelists as well.
Oh, good.
People as panelists so that we can see and hear people for the cheer. So that's an opportunity to see people as well.
Fantastic.
Yeah.
Fantastic. I'm waiting. Okay, we're getting to the 200. Let's start.
Yeah. And
Excellent.
so I've already introduced the team and said what these webinars are about. So you can get straight
into already. Fantastic.
Yep, you can get straight into the updates.
Fantastic. So excellent. So the slides will cover some of the updates. Since then, there have been more updates. So this is what RNAO is asking. Universal. So this is for residential care. Universal masking, which we have been for a month already asking. Pre-outbreak testing and surveillance. And let me explain about that. This means actually testing every single resident and every staff that works in a nursing home. And the reason why this is very, very important is because it gives you a snapshot, a very accurate snapshot of each home for clinical care and for case and contact tracing, because those people that are coming in, if they're staff, they're going somewhere else, including their families. And also, of course, then for isolation. And it also gives you the snapshot for surveillance to understand what's happening for after this round, to make sure that we are not still having a foci inside the homes. So that goes with the robust case and contact tracing, self-isolation of confirmed cases, and then workers should work in only one facility. And we are saying in purpose full-time, and that is for those that are saying, well, but you know, people are working in 3 places because they cannot make a living, etc., etc. That's why we're specifying that it be full-time. And if you think, if a home has 4 people part-time, 1 of those will work or 2 of those will work full-time, and the others hopefully will work full-time in the other places that they're working. And if not, that's where the province needs to step up to the plate and augment compensation, as is happening in BC, because this is how in BC they have been able to control a bit a lot the outbreaks. What's important, and I was saying the slides are up to date, as up to date they can be, is because the feds today stepped up too, and basically gave a directive for universal masking for all staff working in nursing homes to the entire country. And that will be in my report tonight. I will put that there. That also has, of course, been the result of RNO vigorously pushing for this at the province and actually starting to compare with other jurisdictions. The fact that we have a federation does not mean that our Canadian Chief Medical Officer of Health, Dr. Tam, cannot put her foot down when a disaster is unfolding, like in Ontario and in Quebec. So that's very important, and I wouldn't be surprised that the other 5 aspects happen too. You know, a bit too late, not little because it's a lot to ask, but a bit late. Nonetheless, any life that we can save and that we can, you know, have for families to embrace after the outbreak, it will be a life of a person that will smile and their families will smile. So that's very, very important. I see people continue to come, and we surpass, for everybody to know, the 200, and that's beautiful, 209. And people can ask us questions anytime. And Susan, when people have questions, simply put your hand up and I will stop and answer any questions. We are working very, very closely with epidemiologists. The curve that you see on the left is what's happening in Ontario vis-a-vis outbreaks in nursing homes and vis-a-vis the number of deaths in nursing homes. The percentage of people that have died in residents of nursing home and retirement homes in Ontario and Quebec outweighs by far, in terms of percentage-wise, any other jurisdiction in Canada. And it is a huge concern to us. And now is a huge concern also overall, I would say. OHA put a statement, and the media is talking a lot about that. But it makes you wonder if organizations that have power in their organization, like RNO, if we would not have been as loud and as clear on what we are demanding as we have been, if indeed this would have just continued to be under notice, not unnoticed, but under notice, which concerns me greatly as a society, and concerns me greatly as a nurse leader in the health system, and of course as a nurse. So we just had the Zoominar, not webinar, the Zoominar with the nurse practitioners that work in long-term care. It was a fantastic group again, with tons of sharing and tons of important information and work that is fantastic. And of course, our long-term care coordinators that work side by side with us and with them. And they're using 3 of the resources that RNO produced, which Heather will give an update, and they confirm that they're using it a lot, and that's very good to know. Let me stop there for just a second, Susan, to see if anyone has questions about this section, because I think
Sure. Yeah.
I think that there will be I think there will be 2, hopefully only 2 chapters highlighted, one in red and one in green, in the COVID-19 pandemic in Ontario. The red one will be residents of nursing homes and retirement homes as the most difficult chapter that ever this province likely had. I keep saying to people, it's likely the most difficult chapter I have experienced in my career, even more than SARS, on the wards that I have worked, simply because I'm sad to say, but I do feel that government at all levels kind of a bit abandoned the sector. So I'm not talking about the nursing homes per se and the people that work in there. They have done heroic work, but I don't feel they got the attention and the support that they needed. And I say that with sadness, because these are residents that we know get very little chance at a ventilator, simply because even with a ventilator, they will not make it given their multiple comorbidities. So when we knew that that's the case, in the view of RNO, we should have put our entire support into protecting them really from having any outbreak. And still we would have had some outbreaks, no doubt, but not the massive number of outbreaks and fatalities we have had. And what saddens me tremendously, and it was on an article in the National Post that was front and center, saying that we're not asking, that we are pleading to do something, and we gave these 5 points that I mentioned that are here, is that we said to families, please, we're asking you not to come to visit, we're asking you to stay away, because we want to protect your loved ones. We want to ensure that we don't bring COVID-19 into the homes by people that are outside. And yet we did. And yet we did bring COVID-19. They didn't start with the home, of course, right? And yet, in the view of RNO, we did not do all we needed to protect. On the other hand, the green chapter is a beautiful chapter that you will see in my report that will come tomorrow, and it's the chapter about Ontario's model, nurse-led model for caring for persons that experience homelessness and that are either awaiting, well, there is a pre-test actually with massive surveillance. It will be, it's happening as we speak, where they look at the people that are more at risk to do not so well if they get COVID, because everybody can get COVID in a shelter when they are so crowded, right? And it's, but those that, you know, we need to be more even attentive. And then people are waiting for testing. So people that are at higher risk will be tested, and those that are awaiting testing, they will await in this new facility that you will hear about. And then it will go all the way to actually the full care of the person, hopefully to recovery, and if terms go in a different way, all the way to palliative care And our wish is that even ventilators be there, and I hope that there will be. This is inner city in Toronto, and it's being, the vision was of Dr. Andrew Bond, who is the medical director of Inner City Health Associates, and also Lee Chapman, who you know, a very respected member of RNO, Dr. Lee Chapman, who 5 years ago lost her own brother, who was homeless at the time, to substance use, to an overdose. And it's a nurse-led model where we facilitated the hiring of 50 via nurses through our system, and very carefully selected by Lee with the help of Matt Kelway, who is our director of policy, who has been seconded now for a few months there. And with also RPNs through We RPNs, and we really feel extremely proud of the care that will be given. Even more beautiful, they now brought on board Doctors Without Borders that have expertise in treating very complex situations in very, as you know, difficult areas of the world, whether it's refugee camps, etc., and that they will be helping to scale up this model. And yeah, that's the picture. And we feel so very proud. I can look at that. I can go at that again after. I just wanted to give 2 chapters, Susan, because if not, I drown in despair.
Yeah, we need to see the green and the positive. Yeah, absolutely.
Yeah, so I don't know if there are questions.
Yeah, there is a question.
We can go back to the slides. And I will obey to the slides now.
Okay, that's fine. Are you okay on this slide, or you want me to go back?
Where can you put the first one just so I follow?
Sure. Okay.
Yeah, perfect.
And I just wanted to let you know of a question that's in the chat box.
Yes.
Tanya is saying, she says, I understand that there is a shortage of nurses in long-term care facilities. However, shouldn't we push for not allowing nurses who are positive to go back to work for 14 days, which I think we are?
Yes, we should.
I hear, but she's saying, I hear
right.
some nurses are told to come back to work if symptoms are mild.
She's right, and that it's called working quarantine, which is beyond me. So the issue of we are short of nurses, we are short of everybody in nursing homes, and we have been for the last 20 years. And RNO has been pushing and advocating for a different funding model and also different staffing model. And that was in my report 3 days ago. And feel free to go to the blog. You will see that all there with the references to how long we have been at it. Interestingly enough, though, right now, actually, they could do without that nurse and have that nurse in 14-day self-isolation. So to protect the residents, to protect our other colleagues, to protect, quite frankly, themselves and their families, because we have Via Nurse. And Via Nurse, anybody that connects with our team at Via Nurse, in a matter of hours, they get more applications than what they can dream about. So if any, and it's free of charge, not a penny. So now is not the time to actually say, oh, you need to come back to work sick. My colleagues, Irma Jean and Irma Jean, by the way, is back covering for Matthew as acting director until Matthew is back. Hi, Irma Jean, in policy this time. And my colleague, Heather, we were with the NPs and we heard from one of the nurse practitioners, Mike, who works in a home that has no COVID positive, that is preparing madly, just in case, doing everything. I asked him to write me a piece for the blog because they're doing everything that in the books would say you need to do. Okay, they're using universal masking. They're really attentive. They already have a place for isolation. If someone is sick, let alone with symptoms like COVID, Susan, if someone is sick of anything, they say stay home. And my colleagues know that that's the policy I have at Arenos. In the moment I step in, years ago, and our sick time has decreased, and people feel they can take care of themselves and not put at risk anybody else. So no, please, if you hear people saying, oh, but we cannot spare you, say, have you approached via nurse rather than bring someone that should be in isolation? That would be my answer to the colleague, to Tanya, that posed the question. Any other comments or questions here, Susan? Any other questions? You are on mute.
Yes, I know. Yes, thank you. There's a question saying, I've been a nurse for a long time, but recently started as a casual RN in long-term care, which is a new environment for me. And the reality is that I'm casual, still on probation, and I'm not getting enough hours to support myself. I need another job to support myself and family, but my hands are tied. So there's someone who's asking that question, that's RR who's asking that question, and then someone else saying advocating for higher wages in long-term care. So
very good point. Two things about that. There is no directive from the province at this point. This is RNO saying one employer. There is no directive for that. So I don't want to hear you work in many places, but you do need to sustain yourself. The other piece on the higher wages, one of the colleagues in long-term care sent me a fantastic email yesterday that I will put in one of the reports, and also we will take it forward to work with policy, because her idea was that we should harmonize all the wages across all sectors for any healthcare worker. And she said for physios, OTs, nurses, PSWs, RNs, RPNs, NPs, etc. And that will solve this issue of always someone is the poor cousin here, whether it is primary care, which is the lowest of the lowest, or it is long-term care, or it is home care, etc. So I think that's a very important point, because as long as the wages continue to have that disparity, so primary care now is not the lowest. Primary care actually for NPs at least is one of the highest. But I think we need to really do something, and maybe this difficult situation that we are in will lead to some silver linings like that. So thank you for the comment, and feel free to send me an email on that if you want also.
Yes. Can I ask another one from Leanne? Leanne is pointing out another risk group that are homes for people who are developmentally delayed. And often those homes are staffed by regular people without a health background, she's saying?
Yeah, so we have the example of participation home that happened either late last week or, yeah, late last week. So I do need to tell you specifically to that home first. That is a home for different abilities people, more than disabled, and that you are correct. There is all unregulated individuals and volunteers, etc. So when we hear about an outbreak like it happened there, and they were without staff because many staff were sent home to self-isolate, we don't even wait for them to contact us, we immediately contact them. In the case of Participation House, I do want you to know, not only my director of membership, who is the person that is running with his team via nurse, connected, called, and left an email. Also, I did, and I have not heard back at all. So I don't know if it is because they're simply drowning in so much going on, but I have said this before to all of you. I know that when there is an outbreak and they send half of your people home to self-isolate, that you are kind of, what do I do next? Please, what you do next is see how those residents in each one of those rooms are, because we don't want to find ourselves in the situation of what happened in Quebec, which is horrible, right? The second is, you absolutely need to approach via nurse and get people in, because if you don't people in, you will continue to go like this. So you need to get people in. Yes, it will take time, but even if we need to help you sort and help you narrow to 10 people, we will help you, but you need to get the resources that you need. And the province did put money to participation home after. So don't think about the money now, get the resources you need, because I'm sure they will bail you out after, but you need to give the care that people need and deserve. So I don't know if that helps, but it's a very good point. And we did ask already several times for guidelines for people in co-op type of housing or supportive housing or group housing. There are all kinds of different models, right? We did ask for guidelines and they're forthcoming, so they will be in my report.
Doris, I just wanted to point out what June is saying too, which is a nice idea. She's saying that there are a number of long-term care homes that are doing really well. And perhaps after this, we need to look at what they did right.
So this is why I asked Mike to send me a little paragraph, both to look after, but also now. It's kind of so heavy if we only hear about the outbreaks, right? Which are massive and numbers of people that are dying as a result, and the staff that are suffering with that, and the management and everybody, right? But there are some that are doing very good. So I think maybe, Susan, why don't we invite for the next meeting, Villa Colombo, invite Tracy, please, to present, and let's invite Heather Mike that just shared with us at the NP Forum.
Okay.
And it will be great that they can hear two homes that are doing, hopefully by then also, hopefully by then also,
yes.
But they're well prepared, and I think will be great to hear positives. Yes.
Yeah. Yeah.
Thank you for the suggestion to the colleague that spoke. Yes.
Yeah. Yeah, that's great. Another point from Diane, or a question from Diane. Diane's remembering back to SARS and thought that there was a model that was developed there where staff were only allowed to work at one facility, yes. Wondering what happened.
That was Areneo asking back then too.
Asking, okay.
Yeah, and we are asking that again, and already for several weeks, right? The issue is this: during SARS, remember, it was pretty localized, right? Comparatively speaking, in terms of numbers, etc. So in a sense, was perhaps a bit easier to say one employer. But if you remember, there was another piece during SARS. Back then, less than 50% of the RNs were working full time. So the great majority, in fact, not only of PSWs and not only of RPNs, but even of RNs, the great majority were working in 2 or 3 employers. At least on the RN side now, the situation is better. RPN somehow better, and PSWs is a disaster. About 40 to 45% of PSWs work for 2 or 3 employers or homes, simply because they don't have full time, not because they want to work for 3 homes. No one wants to work for 2 or 3. Everybody prefers to be attached to one. So the learning of that is truly, how much did we learn from SARS, Diane? Question mark, right? And why is it taking so long this time to implement? Well, because the model that we have is that exactly a disaster model from a funding perspective, which Areneo has been speaking about that, and from a staffing perspective, we are amongst the lowest staff, both in terms of skill mix and ratio. RN, RPN, and PSW, and what we have been asking for, I mean, since 2010, we have been asking for at least 20% RNs, 25% RPNs, and no more than 55% PSWs. Not because PSWs are not wonderful people, they are, but we need the knowledge and skills in best of times, given the complexity of residents. We need that in the homes, and in difficult times like now, just imagine, right?
So Doris, my phone just went off, my alarm for 7:15, which is the reminder that we wanted to promote people to panelists who want to be. So Olivia needs a bit of time to do that. So it's not time to make noise yet, but it's time to promote people to panelists so that we can see their faces. And for those of you who are wondering what we're talking about is we're preparing for a 7:30 cheer for health workers. Oh, Doris, that's going to be loud. So we're not ready yet, Doris, for the cheer. It's only 7:16, but we need to promote people to panelists. So Olivia, how do you want to do this?
Hi everyone, Olivia's here. If
people with tools, Olivia, people with tools.
Yes. So if you'd like to be promoted to a panelist, and what that means is then your video will be shown and you can join in live with the cheer. So pots and pans, whatever tools you have in the house to join the cheer. If you'd like to have your video shown, please write in the chat box either yes or your name, and I'll take the next 15 minutes or so to start promoting you as panelists.
Okay, so do we let them promote themselves? Don't charge us money for that. Promotion.
Happening as we speak, Doris. So that will Olivia's doing that as we're continuing on.
Very good. Okay, next slide.
And I don't think any more questions, more comments, and I've suggested that Jean take a look at some of those because they're kind of policy related, but maybe we'll move to this next slide here about what we're doing to support nursing homes.
Very good. So I spoke about Via Nurse. You want to go with it, Heather, please?
Doris, I'm wondering if while you're on that issue of Via Nurse, we do have a question here that says, I registered with your Via Nurse in March. No one is getting back to me. I would love to help.
I know. Thank you very much, Imogen. So the reality is, and we wrote a couple of times to people to know they will connect with you if the request from your area comes and then it gets triggered. It means people in that area either have not asked or when we have sent the, that's likely the situation. The reality is we have 9,000. We never thought that we will have such a massive, fantastic response, right? So we have served many, over 100 nursing homes and numerous hospitals and also a few indigenous communities. That's not to say that they still will not contact you, but if you know in your local area, you can approach them too, right? And say that you're ready to help, like call your local hospital or public health unit for contact tracing. But it means they have not approached, they have not asked for resources. Thank you for telling me, Imogen. That's a good point. Heather, you want to go through this? You're on mute.
Sure. No, I am on mute, but I'm not any longer. So Via Nurse, just a reminder to everyone that, just as Doris has said, we've got a large number of individuals who have expressed an interest in helping to support the health surge capacity. This includes the opportunity for volunteers to come forward, as well for paid positions, as well as organizations who are seeking support. So we have nursing students seeking PSW positions, and those continue to be filled as we move ahead. These are paid positions, and again, these are second, third, or fourth year nursing students that are available to help with this work. We've also got a Via Nurse site for critical care nurses, being able to support emergency department, step-down units, ICU, for example, and also virtual and clinical care. So again, doing contract tracing, etc., that would be virtual care, but also clinical care for those situations where NPs and RNs are needed. And then we've also got recently, in the last little while, just released the nurse practitioner Via Nurse, which again is really focusing on nurses NPs, is specifically working in primary care, adult care, and pediatrics and gerontology. So those are all available as well. And again, this specific focus there as well for Indigenous health resources. NP support. So we've started having, about 2 weeks ago now, NP meetings with nurse practitioners predominantly working in long-term care. We've been having those twice a week, Mondays and Thursdays. So we just literally finished one just immediately prior to coming onto this call. And it's through these webinars and knowledge exchange meetings that we're hearing about issues in the field things that NPs need supports with. And as a result of that, we've been developing and have developed and released a number of different resources in the last 10 days. A resource that focuses on isolating residents in long-term care, some best practices, suggestions, ideas that have come forth from the long-term care sector. This is more about practical solutions and strategies that have been utilized to help support that particular issue, both for COVID positive, those pending results, and residents who are healthy and needing to continue on with their day-to-day lives as best as possible. We've also developed a resource that's focusing on palliative care and end-of-life care resources. And again, those are available to all. It's not specific to long-term care, but provides a number of different resources and supports for palliative and end-of-life care. And then finally, a resource focusing on mental health and well-being. And so all of these are available, linked through Doris's update on as of Friday, as well as on our COVID page. So you can find those resources there. And we've also released via families. So this is our Facebook groups related to providing supports for a number of different individuals. And again, these came forward from our work with the NPs. So 2 weeks in now for our Facebook group called Connecting Families. And this is for families of long-term care residents who have loved ones in long-term care who are looking for social support. We have about 150 plus members of that group. And they're actively discussing and sharing resources for how to keep in touch with their loved ones, have an opportunity to ask questions, etc. We also have 2 other Facebook groups that we just launched last week. And so we have over 50 members in both of those as of Friday. One focusing on peer-to-peer support during COVID-19. And again, this is really meant for healthcare providers to have a place to go and talk to each other about their experiences, and also one called Sharing and Tackling Emerging Care Issues Together. And this is really, again, a way of sharing strategies, successes, challenges, and ideas about moving forward in this day of COVID-19. So all of these Facebook forums are moderated by our NAO staff members, either through our practice team, our implementation scientists, and others, and our policy team to help support, guide the discussion, provide resources, gather ideas, identify tools and resources that would be useful so that we can best respond to your needs. And so I think, Doris, yeah.
If you could give me a brief, even not today, tomorrow, update on numbers. And I want to clarify a couple of things because a couple of questions came to me about this. These groups are not for research. So overall, they're not for research. And on the issue of the via families, is only for families and the moderating people of RNAO, nobody else, please, whoever is moderating, Heather, that's very important, yep. Okay? And then as for the others, of course, it's for staff, meaning for colleagues that need the support, etc. But again, those are not for research. We have not asked permission, nor will we, because that's not the intent. So I just wanted to clarify because I got 2 emails on that issue of people that are interested in doing some analysis, etc. That's not the purpose. Not the purpose, not the time. So thank you very much. And I'm so glad that already 50 people registered.
Yes, we are too, over the holiday weekend. So that was fabulous. And our team is responding to them and supporting as best they can right now.
That's amazing. That's amazing. So for those of you, the over 200 participants, if any of you think that is something else that we should be doing, we have some ideas that we are cooking, and I'm not going to spill the beans yet, but that they are exciting. If they materialize, we will let you know. But if any of you have ideas of things that will be helpful in addition to what we are doing, by all means. If people need additional resources for mental health or social support or whatever, please let us know. Channel them through Susan or through Olivia. Susan, how do we go with the group? If they have ideas, or through Heather, who is taking the ideas?
Yeah, well, if they want to post, if they want to join the Facebook group And one of the Facebook groups, we'd love to have the ideas through there because that's an existing channel.
That's good, but I'm talking in addition to what Heather is sharing.
Yeah, and then they can probably to Olivia because they already have Olivia's email.
Fantastic.
It'd be easiest for them. Yeah.
So we are always prepared and ready to do some additional ideas. Excellent. Next slide, please. Are there questions on this? I should ask first.
Well, there are questions, but they're coming up. They're going to be kind of addressed when you talk about some other things. So
Very good. Very good.
Well, maybe while we're still on Be a Nurse, I should, or in that area, there was a question about the ON workforce registry and how we dovetail with that.
So very good. So I can comment. First of all, Be a Nurse started about a month ago. So we started way before the ministry. Second of all, both are supports. The ministry is extremely happy that we are continuing with that, and so are employers. So it doesn't necessarily dovetail, but people can go here and there. Bottom line, they need to find their resources, and that's the only thing that matters. So it's working very well. Thank you for asking, Irma-Jean. And there has been no real issue. I am in touch with David Lamb, who leads that, and perfect.
Good.
So same goes for that. Remember, there is something important here. We only serve RNs and Ps and PSWs, right? So the ONT serves cleaners, for example, social workers, any other profession. And cleaners, by the way, is one area that there is a huge shortage, because remember, in a nursing home, you don't have, many cleaners. You have a few cleaners that work there all the time. And if they need to go in self-isolation, imagine, and in the face of COVID. So cleaners, both in hospitals and especially in nursing homes and retirement homes, has been an issue. Yeah.
So actually it's very specific to nursing, ours, whereas it's the entire workforce in the Ontario
That's correct.
workforce. Yeah.
Yes. And doctors have their own too, by the way. Yes.
It's 7:28.
Okay, so.
It seems like it might be a good time for us to.
So do we have people signing in? Did we promote a lot of people?
A lot said yes. They
We
wanted to be
Olivia, I think, has been
visible.
working on that.
Yeah, so we promoted quite a few people. It's not too late, so if you'd still like to be videoed, just enter into the chat. And
How many more you need? We want to be full. How many more?
We have 23 right now, so we would have a full screen. I just want to remind everyone that to start your video, you do have to go to the bottom left-hand corner. There's a video camera icon. Just click on it, and then your video will start.
And what do we do? Wait. Do I need to do anything? No.
You just need to cheer, Doris.
Olivia, can you then, I don't know if you can today, but if not tomorrow, send the picture to everybody?
Yep, absolutely.
Because then people can tweet themselves. It's fun.
Yep.
Thank you.
You're welcome.
And to all of us, thank you. You tell us, you count.
Okay, everyone start your cameras and start cheering.
Healthcare workers to essential services, thank you. Together we can
do it.
Together we can do it. Thank you to everybody.
You can see the screen. Everybody, we have hundreds of nurses.
Wow.
That's great.
That's
Thank you all for
Thank you,
participating.
guys. That's lovely. Oh, now I can see faces. Victoria, Angela. Oh, I like that.
I'm going to mute my line because there's a racket outside with my husband making noise. So.
Very good, very good. So these are really the 4 vulnerable communities that RNO has been absolutely laser focused on. Number 1, as I said first, nursing homes, both nursing homes and retirement homes. I do need to tell you that retirement homes took me as a surprise, even to me, because I didn't expect, I don't know why, because they live more in private rooms, and I have retirement homes kind of as healthy people all the time in my head, so I didn't really predict that it will be such a difficult situation as it is being, because it is, okay? And these are people, remember, that are not in a system like nursing homes, that if they don't have the means, they don't need to pay as it is in nursing homes. Retirement homes, people pay a lot of money. And just, I mean, yeah. So that's one community that for us is vulnerable, that we have been very, very focused on. Protecting people in shelters and persons that experience homelessness that are COVID positive is hugely important to us. And let me differentiate, Anna, if you look at the press release from RNO today, which Olivia, if we, well, I will put it in my report, so don't worry. The difference between the vulnerability of people in nursing homes versus shelters is significant. Both are extremely vulnerable. Both live in very close quarters. In fact, one could argue easily that in shelters, they live in close quarters, even more so than in retirement homes. However, the people in shelters, they live in close quarters usually at night. That's where they sleep. During the day, they're out and about. So when people in good times, don't pay attention to the health and well-being of people in shelters, not only is outrageous in the view of RNO as human beings, it's outrageous from a public health perspective, because they're out and about during the day. So whatever they, they have, whether it's TB, whether it is, in this case, COVID plus, or whether it is influenza, is a public health distribution to everybody, if one can think from a public health perspective. So we are absolutely thrilled, number 1, because people that live in shelters are people like you and I and anybody else, right? That fell into circumstances that are a tragedy for them and for their families and for any of us. One is too many. That live in crowded places because we as a society and governments at all levels as governments have not found better solutions than having them live in crowded spaces. And that now in COVID, they are 4 times more at risk, not only of contracting COVID, but then the related fatalities out of that. So the fact that we have launched a full initiative thanks to Inner City, Toronto, helped immensely by Doctors Without Borders, Canada, is just heartwarming, and it will be probably a model to emulate, not only here in Canada, but actually around the world in years to come for epidemics, not only for pandemics. So that is really beautiful. Corrections is the other one that we are just waiting to see the fire, and we have spoken with the government and during our meetings and asked the guidelines, etc. Because again, if you think, it's a group that lives in very close quarters, right? And they eat alone, they eat together, and they're together sometimes in cells, etc., etc. A bit akin to, I see you, Susan, a bit akin to really people in nursing homes, just a younger generation, usually, right? but very, very concerning. And there have been outbreaks in some parts of the province, small ones, and in some parts of the country for sure. And in the US, it has been a disaster. It has been such a disaster of riots inside the correctional facilities, to the point that at one point they wanted to start to let people out just not to have so much crowdiness. Very difficult. So that's another one. Indigenous communities, I think the silver lining is that there has been very little happening, but a lot of planning happening. And I'm not going to give details, but RNO is extremely involved in the planning as we speak. And I'm tremendously proud of our leaders, especially Sabrina Mirali, who is an expert of working with indigenous communities, and Grace Suba, which have been working with indigenous communities for the last 10 years. And they are working with Imagine and I and a few other people that at this point we will not share more, just out of respect to them. But I think it will be hopefully another good chapter in the history of COVID-19. So that is, I think, very important. And the items to tackle are the same 5 items, no different, right? 5 items in terms of broad umbrella, and then each one of those need to be worked in detail. But this is the way to really tackle the situation. The picture on the right there is actually a picture of the nurses that are working in inner city Toronto. This was the day they opened last week, and at that day when they sent me that picture, they already had in a few hours they already had 13 people, and now they have a lot more, and they have up to 50 nurses that they have hired, and they will be deploying them as the need comes. And I'm sure if they will need more, they will receive, we will support them with more, and so will the province. Kudos to the premier on this file, not on the one of nursing homes, but on this one, yes, to the premier and to the minister for having understood the importance of this nurse-led model. And kudos to to John Tory for having put also resources alongside the province. They all put resources behind this, and we needed to make sure that the place also met all the standards for infection control, both for the clients that they will attend, also for the staff that will be working there. So we are extremely proud, and Lee shared with me, Dr. Lee Chapman shared with me that the nurses that are working there and other support staff, including harm reduction experts that work, they're fantastic. She said to me, they're fantastic. And as I said, we did segment from our group when Heather developed with us the survey for all the populations. There was a section specifically about expertise in working with indigenous communities. So we did send them really the cream of the cream of people that not only have expertise working with persons that experience homelessness, but also expertise with indigenous communities, in case that some of those individuals are needing that expertise. So it's beautiful. It's beautiful. Yes. Questions on this? Yep, go for it.
There's one listed here that what about the people within the detention centers? What's being done for them to release them so that they are not really in that situation and at risk for COVID-19?
Yeah, I don't know.
Detention centers.
Yeah, I don't know the specifics of what to do to release them. What we are asking very much, and there were some guidelines of what actually, how to tackle the prevention of outbreaks of COVID-19. Don't forget that the issue of visitors is less, and if staff are using all this universal masking, etc., hopefully we will not see the outbreaking mess that there is in the US, right? So hopefully. By the way, the US likely will be the jurisdiction with the highest, not only cases, but number of fatalities worldwide at the end of this ordeal. A very sad situation, very sad.
Yeah.
And specifically New York, they're doing a bit better, but terrible situation, very difficult. And colleagues that speak there and that send us notes, I tip my hat. I tip my hat. And people from all over have been going there to help from all over. So if some of our VIA nurses, that's something that we never ask, want to go to other jurisdictions, maybe Heather, we need to talk with Daniel at some point. I know Daniel is doing a survey to see what's the need in the field and how many more they will need, etc. Maybe another question is to the VIA nurses, if they would like to volunteer for other jurisdictions, and if they give permission, we can pass on their names, because we cannot take, of course, responsibility of anything. You will need to be hired, same as here, by someone over there, by someone, but yeah. Yes, other questions, comments?
I think some of the other questions are going to be covered with our Q&A, the questions that people submitted. And it's 7:42 now. So maybe what I'll do is kind of quickly go through some of these slides and get straight to those questions.
Yes.
So this is a link to the 17 urgent steps for government, our advocacy work. And we did go over that last week. So maybe that's just a reference for your future reading if you are not aware of those. And I counted today, Doris, we've got 137 media hits.
137. I can feel it.
So that's the latest count there.
So if colleagues on the field would like to be exposed to media, colleagues, especially colleagues that are working, that's a question that they can send then to Olivia and pass it on to me before we send to Marianne, Susan. So if colleagues want to speak about their work on the field, to tell us who they are, that they are, you know, free to speak, because we cannot then be legally.
You mean allowed to speak?
Well, I don't know if, you see, I don't know if people all need to ask permission if you're a consultant, you know, and if you're not disclosing which home or which hospital. That's why I'm saying if you are, you know, not allowed means someone is giving you permission. That's up to you if you ask permission. So if they're able to speak and take responsibility for that, we wouldn't start to check, and we wouldn't, you know, take that's the issue with nursing, that sometimes they're not allowed, right? As opposed to doctors. That's why you see doctors so much well, we are a lot in the media more than doctors, so I shouldn't be saying that. But hey, I am allowed to speak. I'm able to speak. I want some of my colleagues, if they want to speak and they're able to speak, to tell us basically who they are, the phone number, the email, and where do they work, and what do they think they would be speaking about, so that we can get a sense.
One of our calls to action for tonight. Anyone on the line?
Yeah,
Great.
yeah, but with some specific questions, so we have some info. Excellent, excellent.
Okay, so you want some other questions that I have here?
Sure, yes.
Okay, so one is, when is the government going to give NPs an OHIP billing code?
Good question. Good question. The last I heard in one of the emails I got, and I really didn't hear the minister say that, but if the person wrote, I'm assuming they did, with the issue of telehealth and the wait times, that one of the suggestions was called doctor's offices. Not a good suggestion, because that will cost a lot of money for a consult of, this is what I feel, should I go to be tested versus, you know, telehealth, that's what they do. So our suggestion is always add more nurses to telehealth and to any other calling center. I don't know, that's a good question. And it's a question not only pertinent to this, but in general, we will check on it.
Okay. The other is, workers who have pre-existing lung conditions, COPD, bad asthma, should they not be put off work by a doctor so they don't become the next ventilated patient?
No, they shouldn't be put off work at all. They should be put off working with COVID suspected or positive patients. And all the organizations, whether it's hospitals or home care, for example, etc., they do have, they do make sure that when a worker of whichever discipline discloses that has preconditions, that they actually are accommodating for that, and I'm aware of many that are. Yeah.
Yes, me as well. Okay.
And the same, by the way, has been, and we heard that in other groups, for people that are 70 over, you know, there is a 70 and there is a 70. That's for you to disclose to your employer how vulnerable you feel you are, because you can be 70 without any preconditions and you can be 50 with a lot of preconditions. So those are issues that are critical that you discuss with your employer, because we have had the opposite. We have had colleagues that say, hey, I'm 72 and I'm in fantastic shape and I do want to help and I do have the expertise to work with COVID positive patients and I'm willing to. Also that, the other side of the coin needs to be discussed with your employer.
And Doris, just along the similar lines, someone was asking about pregnancy. Would
Pregnancy is the same situation. Pregnancy is the same situation. Now, there is a little bit of a higher risk for pregnant women vis-a-vis COVID, but on the other hand, these are very young individuals, so there is no pattern here that there is greater complications actually. But again, if I was you, I would disclose to the employer and I will say I don't feel comfortable because, you know, so, and then you discuss that with the employer. I'm sure that employers, especially if you are either very early on the pregnancy or very late, they will accommodate for that.
And I've spoken to nurses and that is what is happening.
Yeah, and I'm talking about working with patients that are suspected or COVID positive. I am not talking about leaving work. That's a very different situation, and the same as the previous question, the answer is no, no reason for it.
Okay, I have a question here about future advocacy work. Little coverage in BSEN programs that relate specifically to working with adults with developmental disabilities. Need to improve collaboration between nurses and developmental service workers.
Excellent, excellent.
Good point.
Agree. Agree,
now,
and actually that's something to take post-COVID in terms of clinical placements. When people say we don't have enough clinical placement, we don't have enough, this is an area where I have not heard in the past that we send students, so fantastic point, well taken.
Okay, and then there's plenty of PSWs who don't have formal qualifications. And this person is saying, well, I agree they should be regulated and accountable. These without qualifications are not going to be able to register. Many will just quit instead of taking courses.
So first of all, PSWs are not regulated. So let's clarify that. They're not regulated, nor is RNO a supporting regulation of PSWs because they don't have a unique body of knowledge. In relationship to COVID specifically, there was early on a directive that actually even volunteers can work in nursing homes now. So let alone PSWs, right? The problem is when issues happen, like it happened in several of the outbreaks, many of these individuals, because they're working in 3 places, they say, I'm out of here, simply because they're paid insufficiently. They work in 3 places and they're not willing to put their families at risk. They're many times the only breadwinners. So it's a complicated issue that hopefully will get the deserved attention. Hopefully the entire sector will get the deserved attention once and for all post-COVID. Now is not the time, but post-COVID. And RNAO will put a model, a completely revamping, not anymore just the issue of funding and staffing, but actually a complete revamping of how long-term care should work in this program.
Okay. There was a question here. I'm just looking down. I'm an RN and an ER going back to work after maternity leave. I've been told we only have level 1 surgical masks available to us. Are these sufficient PPE or is that insufficient for COVID?
So unless you do hydrolyzed procedures, right, then you need something else. If it is for regular care, that is what is recommended in the guidelines. And RNAO all along has been standing by those guidelines. And now, as you know, ONA put a release that was agreed upon, ONA and OHA and the government, that the nurse at the end of the day needs to use his or her clinical judgment. And we support that because, you know, depending what you're doing with that patient, you will know if that's sufficient or not. If you see that you're doing a procedure that will have big droplets, that's insufficient. But if it is because you're talking and you know you're doing procedures that are not, then it's sufficient. But use your judgment, please.
Yeah. Is this a young woman I know with symptoms called the COVID-19 hotline? She wasn't called back for 5 days. When she was called, she was told she didn't meet the requirement to be tested. I'm one of the nurses that offered to volunteer my services as a virtual or telephone nurse. Can you comment on why this is happening?
This is happening a lot and it's not something that we are supporting. And hopefully with the Premier saying that he is frustrated by the so slow progress in scaling up testing, this will change. The province is testing about 4,000, 4,500 people a day. Actually up to a few days ago, even less, because there was a backlog in the labs, etc. Now the backlog is cleared up. The province says that it will scale up the daily testing up to 16,000 by the end of April. And we are saying that needs to happen a lot before end of April for the reasons that not only is important for clinical care, but also for case and contact tracing, as well as for surveillance, so that when finally we will be told, okay, we are reopening the province for business, that when we go out and about, we have actually a good handle of what we are getting out and about, right? And that's why in countries that have done well, the level of testing is massively more than here in Canada overall, and Ontario is amongst the lowest in the country. Well, I think it's the lowest in fact, because Quebec is testing a lot. So we need to improve that, and it's not good that we're not. So stay tuned, we will continue to push for that. That, by the way, I would advise you that you go, so when you go to my report now, you can go and search through the blog by topic. If you will put testing by topic, you will get a whole document that speaks about all the reasons for testing, and it's very, very thorough. And that report was supported by David Fishman, who is an absolute top epidemiologist who I respect hugely. I have met all kinds of people, all of them virtual, either because they have approached me or I have approached them. But I am looking forward to meeting some of them in person one day, because I never met them before. And they're really top people that I just, I have come to admire big time.
Okay, and you were saying
if we can, it's 7:55 right now, and on the screen I've got the questions that people had submitted in advance of the webinar, hoping that we would get to them.
Good idea.
So I wonder if we can do those focus on those, and maybe that'll help to answer some of the ones that have gone in the chat box. So one question, I'll just go from the top about palliative care. So what are the plans for palliative or hospice care support? Because we're anticipating so many deaths, and many people will not want life support and would rather stay at home and be comfortable than at hospital away from all of their loved ones. So did you want to say anything about that?
So you are right. Most people, I think that would be me if I put myself in that situation, wouldn't want, huge life supports and would like to be, comfortable, helped with their loved ones, etc. Here is where the province, in the view of RNO, has fallen short in terms of our model. We have done better in normal times of enabling people to pass away at home, helped by palliative care, even actually by assisted dying. If you see, we have done better of allowing people to do that in the comfort of their home with their loved ones. With COVID, somehow we turned everything into hospital, and it is unclear who drove that model. But when you look at places that are doing well now, in addition to the ones I mentioned, one of the ones that is starting to shine, and you will see a piece from the Minister of Health there, is Islas Baleares. And I think some of you heard me mention this before. And Islas Baleares, the Balearic Islands in Spain, and in Spain, as you know, has been a disaster story in Madrid and all the big cities. In the Baleares Island, the model is entirely focused on primary care and home care. And I was sharing this with Shirley Sharkey the other day because I was talking with her that we need to increase the noise and the radar on this issue of home care and primary care. Now in the Balearic Island, they're connected. Home care is part of primary care, but they do everything, not only palliative care in the comfort of their home, but even taking care of people when they do the testing. They send you a patrol, they call it, with the nurse, the doctor, and the driver. They do the test in your home, and you stay at home. So right there, right, you have the containment. And it's not a small place. It's Balearic Islands is 2.5 million people, like it's not 100,000 people. So I think we need, someone said before here that I think here or in the NP forum, that we need to learn also from the good things that are happening. I do think we need to learn from other models, because we don't think this will be the end of this. So it may be the end, but then there will be a cluster here and there. And I do think that the time has come for the province to realize that, especially with the Ontario health teams, that really things need to change, that hospitals are fantastic, but hospitals should be kept for the very, very compromised that need the supports of a hospital, in this case, life supports, for example. But then we need to use the other sectors much, much more robustly and much more to the advantage of people to be where they want to be in the way they want to be. So I don't know if that helps, that long answer for that question, but I am totally with it, with the person. There was also the question, and it has come through people from the public that approached us. Now, did you guys like the letter of the 7-year-old? I was so heartwarmed by the letter of the, not 7-year-old, 7th grader. I just wanted to be a nurse. In any case, people from the public that have called us and asked, do I take my father or mother or grandma home, right? Given what's going on. The simple answer will be yes, but it's more complicated than that. You need to be able to take care of that person, take care in a dignified way, do the you know, all the care that person, and then if your answer is still yes, 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 then it's time to think. But the other, and of course, you need to know that the home will keep the space for you, right? So it's difficult questions, but all in all about palliative care, I think we need to respect what people want from an RNO perspective.
Great, thank you. This was a question from someone who is associated with the Ontario Association for Mental Health Professionals, wondering about mental health supports, and are there more regulated providers needed to meet the health needs, like, for example, virtual counseling, because they have a body of regulated professionals who might be able to help.
So Susan, I will need the help of one of you, because it's the third time I think I'm saying this, but I forget to do that after, or I don't have the time. So there is a group of about 400. It was profiled in the Toronto Star, and I commented on that, so
Yes.
that can help you. 400 regulated health professionals. It includes psychologists, social workers, nurses that do CBT, etc. And they are providing counseling virtual, free of charge. And that's the piece that to me was very exciting, free of charge. So let's find that resource and send to people.
Yeah,
so
and if anyone on the line knows the name of it, please put it in the chat box. That will help.
I'm sure that if you will put a mental health support, a virtual counseling, and Doris Grinspun, it will show, not because I am part of it, but if there is a line of RNO saying rah, 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 and especially rah, 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 that is free of charge, and then we will find the link to the actual service there.
Okay, so we'll do some, we'll do some hunting for it. Okay, I'm moving down to the Ontario Clinical Triage Protocol that was just released, I understand. And if it's a concern that an ICU nurse had, and I don't think the webinar that we have tomorrow with the legal webinar can actually answer this. And I'm not sure if you have an answer, but if we start giving palliative sedation to patients who've been triaged out of medical ventilation during a surge, through the use of this protocol, are we covered somehow by relevant law, or could we be charged?
We are covered because your organization is allowing you to do that. And in fact, it's asking you to do that through the guideline. So it will be considered clinical treatment.
Okay.
Yeah.
They were citing another case that was thrown out of court that where there was a concern about that from a different.
But was thrown out of court, you see.
Yeah. Okay, and then it's still on ICU.
Now, together with that, what I would suggest to the colleague that asked that and anybody else is that really the conversations with families, right? The conversations with families are critical in nursing homes as well as in a hospital, right? So the conversation about, look, if things don't go as well as we hope, right? And to have the conversation also with the person, with the patient, and with the resident, between families and residents, and then hopefully to document in advance, right? So that will prevent some of those issues of court and thrown out of court.
Yeah, great, thank you.
And those are important conversations
they
to
really
be prepared.
Are. Yeah, and in the chat box, some other important conversations, Nikki's referring to a decision aid link through the Ottawa Hospital Research Institute. And some decisions about care for people who are, I think, long-term care retirement homes. So going back to this list here of questions, ICU nurses, and I've had another similar question. Should they not be wearing masks at all times? Should staff?
The answer is yes, and that has been already well established. The universal masking, most hospitals are doing it. So I'm surprised to see not. Of course, we are talking about this, not an N95 if you're not taking care of a patient that needs an N95, right? Yeah.
Yeah, so staff that come on shift and they're wearing a mask all day long, and they would need to put on an N95 for a certain procedures, but otherwise they're wearing a mask all the time.
Yeah.
Yeah.
Can I comment for a minute just
Yeah.
to give a bit of advance notice to people on what probably is coming? So on Saturday, I think, if I'm not wrong, or Friday, Unity Health put a memo that, and I'm not talking nothing confidential, was in the media and the media called me, that spoke about coming soon, the issue of reprocessed N95 for people. And of course, nurses were, very concerned with that, and that's why the media came to me, and then a few nurses wrote to me. In any case, I took that to the minister directly and to the deputy, just to learn if I had missed a bit here, because what was happening last week and the previous week, as a directive from Health Canada, is that hospitals were collecting the N95 mask at the end of the shift to trial different methods for reprocessing so that the mask could be utilized again, the N95. And when I asked the minister and the deputy if a decision had been made already, they both responded separately to me, no decision has been made. We are still on the phase of testing all of this. Since then, I do want to tell you that I was asked yesterday to comment on a document related to this that comes from Health Canada. And it is my view that the issue of reprocessing and reusing masks that have been reprocessed will come likely to be. What RNO commented on that based on the best knowledge I have and reading all the evidence that there is about it, is that likely there are reprocessing methods that will enable the masks to be safe for people to use. What is critical though is that this thing is, right, not on this mask, because these are not the ones we are talking to reprocess, we are talking N95, but that these ones be not loose, that they be good, right? So that the reprocessing methods don't ruin this, because if not, you cannot fit test well. And what happens with the mask, while the mask may be very good, right, the N95, if it cannot be fit tightly, that's as bad, if not worse, than the mask itself. The other piece, and I am still concerned because I hear from colleagues and I hear from colleagues not only in nursing, that the donning and doffing of a mask is not always mastered by people. Not only that people forget to really wash their hands well before they put the mask, and that they really wash their hands well before they take the mask off, and that they know how to put it. So if you look at my piece yesterday, the one this morning, it has that by a colleague whom I respect hugely, the director of infection control at Michael Garron, who is fantastic, who I basically asked him to give me tips for nurses and for others on how to work with the mask, not about the issue of reusing, etc. Because even if the reusing is good, and even if it's a new N95 out of the package, right? If you guys and everybody on the front lines don't know really how to keep hand hygiene and how to don and doff a mask, you can self-contaminate all the time. And then if these things are loose, so he gives tips even when people are using it's very important that you read that, and it's very important that you practice. Because when you are in the chaos of things happening and you need to do things fast, etc., it will be very easy, like I do with my glasses all the time, right? All the time I'm fixing my glasses. Just picture if you have an N95, it will be very easy to self-contaminate yourself the mask. The other piece that Jeff spoke about is the issue of goggles versus a shield, and he gives the example of the goggles that can snap, and you can really self-inoculate yourself on the eyes, which is a big problem, right? So nose, mouth, eyes, ears, no touching, right? And then the issue of the mask, please practice, practice, practice. And there is a video from him there, which is fantastic. Use it, use it, use it, and share with colleagues. Thank you, Susan. I needed to say that because it weighs on my heart all the time and in my mind.
Yeah, thank you. And in these slides, I summarized some of what he said, and the full details are in your update, which is great. So we're doing well on this list here. A couple of last questions. One is joint efforts between RNAO and CNA, if you want to comment on that.
So I participated, not necessarily joint efforts, but Health Canada called a meeting with all the associations, and we all participated, and we received good information and not many questions. I posed a couple of questions. One of our colleagues from GNA posed a couple of questions. All in all, I think people are, you know, soldering everything, and yeah.
Great.
Yes. Yes.
This last group of questions about accommodations for staff, you've already answered the middle one. And we've been hearing or seeing in the chat box, people are answering the last one about putting frontline staff on like a dedicated line in the grocery store, or advancing in the front line so they can get their groceries. So there's a couple of notes in the chat box answering that question.
Yeah, we could ask about that. That's a possibility, and an easy ask. To the colleague that asked about joint efforts with the CNA, I don't know if you saw the president of CNA and myself in the agenda together. Power and Politics together. The agenda was not with her, was with the president of OMA. But in Power and Politics, you may want to send to people that, send the link to them. And send the link to the agenda too. That was a good, actually the agenda was very good. It was about the duty to care, right?
Right.
Difficult topic, yeah. I must tell you that I have not heard, I have heard of the fears, and those fears are important to speak about, absolutely. But I have not heard of nurses that basically have said, I'm out of here. And I tip my hat for people because, you know, it's simple to say, yeah, you have a duty, but it's much more difficult to be in the front line and actually day in and day out carry the duty with all the other aspects of PPE weighing in your mind. And that's why I keep saying duty to care needs to be matched by duty to protect in terms of ensuring PPE, people have the PPE. So I think between Premier Kenny that said that he will send he has more PPE than what he needs based on the projections of the numbers of persons with COVID positive that they will have, plus the surge capacity that they had to start with. He said that he will be sending some of that surge capacity to Ontario and Quebec. So that's one. Then the Prime Minister mentioned today that now there is a direct connection with China, so there will be more supplies coming, plus the issue of the repurposed or reprocessed mask N95 that should be left, and we are insisting in the document that I review, should be left as a last resource, absolutely last resource. Although some say to me that they may be better than reusing the same mask all the time. So we will listen to the experts there. I'm sure Health Canada will not put something that will put anyone at risk.
Great, thanks. So there are a few more questions in the chat box and one last one here. And it's 8:15. Should we continue with a few more?
Let's do.
Okay, so the last one is
because you still have 144 people.
Yes, the last one on this screen is about free accommodation for healthcare workers who are working on the front lines. Do you want to speak?
Good question. Stay tuned.
Okay.
That's all I'm going to say on that.
Yes, I thought so. Okay. Let me pick
But
out.
I do know that some places, and actually I saw Betty was online. Betty, I don't know if she's still online, but I know in your community, hotels are giving 50% off or something like that. Okay, yes.
Okay.
Sorry, I'm here. I just remuted myself. Yeah, our hotels in Chatham are giving like a 50% rate for any workers. Plus, we're using places that are used normally for residents and interns, as we're a
Excellent.
small community hospital, and those are free if they want to go to those.
Yeah, and I have heard of others like Trent and some other universities that are offering their spaces. I think some at York also. So that's beautiful. That's beautiful.
Yeah, and the YMCA has opened up just for staff to use their showers in the morning and in the evening, so when they go home. So that's been
Excellent.
nice too. Yeah.
Excellent, excellent, excellent.
I have a couple of questions for my ICU nurses. One is a concern about legal liability when repatriated nurses just don't feel like they're meeting their standards of care. So they're concerned about that, and also
Repatriated nurses from other units or what?
I'm not sure where they're repatriated from. If that can be clarified in the chat box.
Probably from other units because they went from step down, from recovery room, etc. Probably that.
Yeah, oh, she didn't answer that.
Yeah, so the issue, of course, that was during the preparations, right? When we started to cancel surgical procedures and surgeries, right? That we, organizations moved people into different units. Ideally, you're moving people that have, alike expertise and skills and knowledge, like from a step down, from a recovery room to an ICU is closer than from an OR to an ICU, right? So they did, though, experience, they are being educated, albeit in a short time compared to the really intense education that critical care nurses have. No different than when I speak with my colleague, Morgan, the president-elect of RNAO, and nurses have been moved from certain units to her unit, from outpatient, for example, and they don't have the same expertise. And I mean, at the end of the day, it's not times as usual, so we can't expect things as usual. So if you feel, though, that a specific or a group of specific people really are putting patients at risk, I'm sure they will not want to be putting patients at risk. So chat with them and the manager, because they probably will be better off in another floor. And to remind all of you, we do have about 900 RNs with current critical care expertise ready to help. So if your organization has a shortage of them, dear nurses, your address, please.
Yeah, and Jacqueline just followed up to say that it was nurses from PACU to ICU, and she's also was wondering about team nursing as an approach to support people who are overwhelmed in those.
Yeah, so I mean, from all the models that I have seen to serve patients during this time, I will buy and stay anytime, and we should ask Vanessa if we can share the slides, Susan, and I have them. I can, if you remind me, I will send her a text this evening, because she actually implemented at Humber River with Natalie Farshite. Humber River is one of our BPSOs, of one of our 500 BPSOs, and it's a stellar one, as many are. And they implemented a model that assures continuity of care and caregiver, not team nursing. despite the repatriation of nurses, etc. So maybe we can invite Susan to the next meeting, Vanessa to speak. I would invite her to speak for like 5 minutes.
Sure.
To give an update, because I think it will be really enriching for people to hear directly from her.
Yeah, and I'd also like to add that the Facebook group, the Sharing and Tackling Care Issues Together, is a really great venue for some of the dialogue that I'm seeing here as well. So if you're interested in continuing the conversation, I think there's some great ideas here in the chat box, and I don't think we'll comment on all of them.
That's great.
A question, I think the answer is...
One other comment around that teamwork is that while you'll be looking at continuity of care for your clients, certainly what I've heard and seen, even that posting on Twitter, is that there's great camaraderie amongst the nurses, physicians, and the whole team that I think really helps nurses feel they're not alone, even though you may be one-on-one with the patient.
Great, that's great.
A couple of questions, Doris, about home care setting and not being provided with enough PPE.
Yes, major issue, major issue, to the point that several of the agencies have taken on themselves to really find new distributors and have bought hundreds of thousands of PPE, not only to protect their staff, really is to protect the clients. And many of the clients, like think about the client with cancer that needs chemo at home, or think about the client with compromised COPD or cardiac or DVT or pulmonary embolies, or like gazillion diagnoses and issues, right? Multiple comorbidities, young or old or in the middle. Many of them are not allowing their staff to come in if they don't have a surgical mask. And I don't blame them. I would do the same. I don't blame them. So the issue of PPE and the issue of lack of really attention again to primary care and home care has been astonishing. As a system, I'm talking, not about the agencies, as a system. Because people continue to have, it's not only the people with COVID, suspected COVID that may need help at home, or with COVID plus that are told stay at home and are not doing, are doing sufficiently good that they want to stay at home. In fact, they need help. But what about people that have all the other conditions that people had before and need help? So yeah, I agree, and it's an issue that we are increasingly speaking about. I connected Shirley with Sandro Contento during the weekend, and she was extensively quoted on a piece by him that, as I said, I asked the minister in Islas Baleares to explain her model. We will be putting tomorrow or the day after a whole piece about home care. And not so much only for this round, but because this is something that we should continue to look at as a health system to really, I'm not saying move away from hospitals, but to deal with the system, right? To deal with the entire health system. Hospital care for when hospital care is needed, for the very critically ill. Primary care to really keep people out of hospitals. Home care to keep people out of hospitals, supported in their communities, all the way from support with the chores in the home, to all the way to care when someone needs the clinical care of a nurse, all the way to palliative care and end-of-life care, and all the way to dying at home if they want assisted dying in normal times, let alone in a situation like this. And of course, the issue of long-term care, which to me is the one that will leave me traumatized, I think, forever. And I do suggest that the system needs a big shake-up, and Ontario health teams are the way to go. I participate in the leadership table of several of the OHTs that RNO is working with, and including during COVID now. And I'm telling you, if anybody thought that OHTs needed to be evaluated, forget it. They need no evaluation. They are performing in a way, at least the ones that we are involved, magnificently, supporting one another. Just inspiring, yes. So yes, I hear you about home care, and you will hear us big and loud more and more.
Okay, so Doris, questions, a few questions are trickling in. I see it's also 8:26. So I'm wondering if some of these might be brought forward to you either for updates or for
send them to me and with the question, and then I can tackle them in the report.
Okay, that sounds
by
great.
all means.
Yeah,
Yes.
that sounds great.
And maybe we can post even this, except that we don't have the answers here, right? And that will mean I will need to write a lot. And as I do, I'm spending hours on the report. But I think, if we can transcribe from the tape to these questions, also we can post them on the report, Susan.
Yeah, so
maybe Olivia can transcribe some of the answers to these questions. Then I can beef them up and put some linkages, and we can ongoingly, if that happens once a week, then we can make them part of the report for the many others that are not part of the 200 in the Zoominar.
Zoominar, yes, very good. Okay, I think that's a good plan. So maybe I'll advance the slides here and just kind of bring this to a close. Those are the trusted.
Is this the Alex? I see Alex. Alex, is this the Alex at the Villa Colombo? Nope. Okay.
Okay.
I don't.
This is
that's okay. Don't be sorry. It's another Alex. Good Alex too.
This is a collage of some of the far and wide.
I love it. Stay there. I love it.
Yeah, yeah.
Or maybe someone can send it to me. This is so neat.
Yeah, well, you have those slides, but.
Right. I forgot, but I have you now with you guys.
Yes.
Smile, Imagine, smile. All of you, smile. Whoever it is that has been promoted.
Imagine, you're on camera.
She's not hearing.
Oh, there she is, yeah.
Okay. Yesterday, I saw such a good piece on a window that said, being at home is not being stuck at home. Being at home is being safe at home. I took a picture of it. It's beautiful.
Yeah, that's nice. Yeah.
So this is the reminder to cheer, everyone. Cheer in whatever way you can at 7:30 every single night. And those are the hashtags. Together we can do it, and cheer for health workers. It's really spread across Canada and
UK.
Yeah, it's all around the world.
It's big time in UK.
Yeah. And it really matters. It makes a difference. This is the webinar I mentioned, legal issues in nursing practice related to COVID. There's one tomorrow and one on April 17th. So you can go to the events page to register for that. And then this next webinar, we'll do this again next Monday, 6:45.
And questions to you or to Olivia, right?
Yes, yeah, to Olivia, and then we'll compile them in advance, get through as many as we can, and to remember just to read Doris's blog, because it does summarize many of the questions that some of you are asking tonight as well.
Excellent, thank you very much. Excellent, and excellent questions from everybody. Keep safe, keep well. Thank you for joining us, and just a privilege to be able to chat together. And maybe let's bring next time a couple of guests, maybe on the issue of models of care delivery, right? 5 minutes, like, I think it will be good. And any other big issue, let's connect.
Great.
Thank you.
Thank you, everyone.
Thank
Okay,
you.
bye.
Take care,
Bye,
everybody.
everyone.
Bye.
Thank you for joining.
Thanks for joining us. Good night.
Good night.
Night, everyone. Thank you.
Thank you.
So Heather, this one is not cross-country Ontario NP.